So we shall now go on to our next speaker, Dr. Gopal Raju, who's again chairman and medical director of Vishaka Eye Hospital, Visakhapatnam. Again, a very eminent surgeon from that area, and in fact, a national figure. So look forward to seeing his video. On to you, Dr. Gopal Raju.
Yeah, thank you, Dr. Chitra, and I thank AIOS ARC for giving me this opportunity. So now my case is, even though everybody thinks dense PCC and PCR is quite common, but each case is a unique situation, and each case is very difficult to predict how they behave. Some of the cases where we expect too much, they sometimes will get away with very easily, and some of the cases where we thought it's very easy, then we will end up in problems. So mainly the reason for identifying this case is I would like to stress some of the important points one should take care while dealing these kind of cases. One is the hydrodeliation that everyone knows, but the type of hydrodelineation, the hydrodelineation should be limited to only the center core of the nucleus. Sometimes we do hydrodelineation close to the epinucleus, and that situations it may cause some problems. So this case, the nucleus removal, the another care one should take care is the bottle height or the pressure inside the chamber should be low. If you have the active fluidics, then we can make the IOP somewhere around 30-36, or otherwise you reduce the bottle height to 70 or 80 millimeters of water. And then after the completion of the nucleus removal, the central hard nucleus removal, if necessary, we can do a little bit of hydrodissection of the epinucleus or the cortex. Here, the one important precaution one should take care, and the thing which I have not done in this case, the mistake is, I tried to remove the cortical matter from the PC. So this is the one important precaution one should take care in the PCC, in dense PCC. If you see here in the insert PIP, where this is the area where it is very dense. So that is the area, the weakest area of the capsule. So it can rupture at any stage of the your cataract surgery, either in the hydrodissection or hydrodelineation or the here. See, I just went there and captured. I think it's purely an iatrogenic or surgeon-induced PCR. Even though if I wouldn't have gone there, then I would have prevented that PCR. So the another important step is to recognize it at a very early stage, keep the chamber deep, and then try to tamponade the PCR. The idea is to prevent further extension. So you can tamponade with the viscoelastic, the cohesive viscoelastic, and then insert if the rent is small. Again, each case we have to analyze depending upon the extent of the PCR, and then go ahead with the insertion of the lens. 3-piece is ideal, or even single piece also can be inserted, and then try to tamponade the PCR with the help of the optic, IOL optic. And then if you see, notice here little bit extension, maybe there is one tag which are extending onto the wound. The take-home message is, it's these cases always you should suspect and then anticipate and recognize at the very early stage, and then analyze depending upon the extent of the PCR. And then, like I already mentioned, the hydrodelineation, and then the lobe bottle height. And that is the PC is always the weakest area. Sometimes when you are inserting the intraocular lens, that time also the PCR can happen, where we always think that we have completed the surgery at the end of, sometimes when you are doing a hydrodissection or the deepening of the chamber and then the stromal hydration and then sealing the wound, sometimes I have seen the PCR can happen. So once it happens, then you can use the tamponade, or if it is large extent, then there is no other go. to do anterior vitrectomy and then put the lens, depending upon the situation. Thank you.
Yes, Dr. Gopal Raju, that was a wonderful video, and I think every step of the way you gave us those take-home points about to do a hydrodelineation right at the center and how you could relax a bit for epinucleus and do a viscodissection or maybe a little bit of hydro. And I somehow feel that was a case of I'm more of an iatrogenic thing than inadvertent thing which can happen. But supposing it was a dense nucleus, how would you do your hydrodelineation?
Yeah,
you believe
we can try 2-3.
out?
Yeah, you can try little, go deep into the nucleus and then try a hydrodelineation, and then make another attempt. Sometimes we'll try to make 2 or 3 delineation cleavages, so that we are debulking the nucleus. Or sometimes you just remove the central part, debulk the nucleus, and then make an attempt. So these are the 2 procedures which we can try.
Dr. Ajay and Dr. Sandeep and Dr. Ramurthy, would you want to add something?
Yeah, Chitra, I think this sort of cases where the nucleus is hard and you can hardly see, I would generally follow Dr. Vasavada's technique of inside-out hydrodelineation. If I get a good trench, yes, and then try to do it, even if I don't get a trench or VA, then I would rotate the tip, just take out one piece and take out from the other piece, and then you'd have some space where you can maneuver this nucleus. Because hard cases, unlike those soft cataract PTC, where you can actually delineate, here it's very hard to do.
Yeah,
I think that's what.
So would you, if you're not able to rotate this nucleus, so maybe 2-3 clock hours you can work on, but the remaining dense part, how would you deal with it?
Yeah, remaining, I just turn the tip, and I mean, if it is lower, say 3 o'clock or 6 o'clock, just get one piece out, chop it out, get the other piece, chop it out, and then use a bit of viscose to get the superior pieces down with it.
Yes. And Dr. Sandeep, if this had been a vertical split, as can occur typically in these polar cataracts, and what would you do? Would you still go ahead and place the IOL in the capsule? I have seen some people doing it in the different videos earlier on, or would you not believe that the capsule is strong enough, assuming that there was no vitreous presenting?
Correct. If there is no vitreous presenting and, and I've been able to clean everything up, I'd probably put the lens still in the bag if the rent is small. But if it is end to end, and I think that the capsular integrity cannot be completely relied upon, I have no hesitation in putting a 3-piece lens in the sulcus and then capturing the optic within the bag. So that way your biometry does not go off, and we are able to do. I mean, it was a beautiful video shown by sir, but there's one comment I saw over there that he came out and then injected the viscoelastic later on. What I would say is that keep your irrigation on, go in with your visco, and after you start injecting visco, you withdraw out. So that way you never lose chamber and your rent will not widen.
Yes, sir, absolutely correct. Yeah. I agree with you.
Dr. Ramurthy, Namrata, anything to add? Or
I think it was the point Sandeep made. I think all of us were itching to say it, because I'm sure Gopal also realized it.
All of us wanted to say it. So, Dr. Gopal also realized that we would say it.
Yeah.
Maybe he wanted to drive home the point that has to be done. And we are very fortunate that in spite of that PCR that you had created did not extend. Usually in posterior polar cataract, what you find is that the tear extends from end to end, as was pointed out. It's almost a horizontal split from one axis to the opposite axis. And in these cases, even if you have done an anterior vitrectomy and if you feel that the support is quite adequate, you can go ahead and implant a lens in the bag also. And if I plan to implant a lens in the bag, I would always opt for a single piece lens, because the opening of these lenses is much more controlled. You manage to put a 3-piece lens in the bag with the presence of a tear. But yes, I'm all for 3-piece lenses. If you lost the capsular support and you want to put the lens in the sulcus, 3-piece is the way to go. But if I feel that it's a small tear and I feel that I can manage with in the bag implantation, I would have gone with a single piece implantation. Otherwise, I think, and as regards Chitra's question as to, in case you have a hard cataract with a posterior polar element, then in these cases, creating a trench and then, doing a mini trench up to the center of the nucleus, then doing a chop. And sometimes the inferior heminucleus can be taken out without much of hydro dissection or hydrodelineation itself. And once you have debulked the capsular bag, then it's possible to do a gentle visco dissection, not filling up the capsular bag, making it tense. But since you have enough space, you can go ahead and do visco dissection and then mobilize the rest of the nucleus and cortex and do the surgery in a more controlled manner.
Yes.
Doing flax probably in such cases also could have edge over.
Always.
Yes, absolutely.
Yes. So wonderful videos we've been seeing this far, and thanks a lot, Dr. Gopal Raju. Do stay
Thank you,
connected, and you could keep adding your valuable comments.